is imaging studies of ligamentous injury, and mainly the imaging studies means the MRI of knee. So before going to details, some basics, that is the basic terminology. One is TE and TR, that is the time to echo, is the amount of the time between the radio frequency pulse and the receipt of the echo signal. And TR is the repetition time, that is the amount of the time between the two successive pulse sequences. T1 sequence, when there is short TE and TR times, and T2 is when longer TE and the TR times. The fat is bright and fluid is black on T1, and fat is black and fluid is bright on T2. So for the fat is shown, that is the high signal intensity in T1 and low in T2. Fluid will be low signal intensity on T1 and high signal intensity on T2. And the cortical bones, menisci, ligaments will be low signal intensity in both T1 and the T2. Fat means the bone marrow fat. So how to identify? So once you see the T1, that is the high signal intensity, you will see the bright colored bone marrow fat. So these are the high signal intensity bone marrow fats will be in the T1, then the low signal intensity will be in the T2, and more dark will be on the star images. So when you see some bone marrow pathologies, we can see the star image. So coming to the protocol of the examination. So there are three cuts, that is the sagittal cut, coronal cut and the axial cut. In the sagittal cut we mainly see the menisci, the cruciates, the quadriceps and the patellar tendons, the bones, the synovial effusion. In coronal cut we mainly see the collaterals, and in axial cut we mainly see the patellar retinocular ligaments. Now coming to the meniscus. So there are two meniscus, the lateral meniscus and the medial meniscus. How to identify which is which meniscus? So the medial meniscus, the lateral meniscus can be identified by the convex shape of the tibia, the presence of the fibula, and by the fact that the anterior horn is equal to the posterior horn. However, the medial meniscus is identified by the concave shape of the tibia, the absence of the fibula, and the fact that the posterior horn of the medial meniscus is longer than the anterior horn. Now meniscal anatomy. There is a gap between both the horns. We can often see that a cut which is taken at the intercondylar notch or on the medial side will have the gap between both the meniscus. While a cut taken more peripheral, the gap reduces and we will have this type in the middle one, that is this type of the meniscus. And a gap and a cut at the periphery will have both the menisci joint and we will have the bow tie sign. Now how to identify which is degeneration and the tear? When a signal, the signal intensity changes is presence in the form of a dot which is not connecting with either of the intra-articular surface, either superior or inferior, it is defined as a degeneration. But when the tear, it is tear when the when the signal intensity, signal abnormality, that is the tear, crosses either of the intra-articular surface, then it is defined as a tear. Now the classification, the type 1 will be like a dot, the type 2 like a line, and the meniscal fraying is there when the medial portion of the meniscus is thinned out. Then there are meniscal tears, the simple tear and the complex tear. The horizontal tear, when the tear running from the meniscocapsular junction to the intra-articular portion, it is a horizontal tear. The vertical tear, it is more common in the posterior horn of the medial meniscus. The radial or the root tear, it is also a type of the vertical tear at the edge of the meniscus, and we can often find that the meniscus is missing in one's cut, but in the next cut the meniscus is present. So this is also known as the ghost meniscus. There are the complex type of the meniscus. A complex type means when there is presence of both the horizontal cut and the vertical cut, and the bucket handle cut. Bucket handle tear is the tear was present in the body of the meniscus, but as the time gradually progresses, then there is separation of the fragment, and it leads to the bucket handle tear, and it leads to the classical double PCL sign. We will see it in the first life surgery case also. Then the meniscocapsular separation. While it is a common phenomenon in the lateral meniscus, but as it is not firmly attached to the capsule, but the medial meniscus is firmly attached to the capsule, so any separation from the capsule, that is the presence of the fluid, is defined as the meniscocapsular separation in the medial meniscus, posterior horn of the medial meniscus. Discoid meniscus, if we find the three sagittal sections, there is the bow tie sign or the body of the meniscus can be found in consecutive three sagittal cards, then it is the discoid meniscus. It is more common in the lateral horn of the lateral meniscus. The cruciates, the ACL and the PCL. The PCL is the most constant structure. So whenever you are trying to see the MRI slides, first look for the PCL, as it is the most constant structure. Then try to look at one or two slides. So first here you look for the PCL. Then at one or two slides anterior or one or two slides posterior, you can find the ACL. So in sagittal view, it is a taut-like structure and is parallel to the intercondylar notch. When there is wavy or sharply angulated, it is the partial tear, and when there is complete discontinuity, it is the total tear or near total tear. Now coming to the coronal view, the ACL, we can find the bony contusion. Like you can see, this is a star image where there is the fat suppression image, and the bone marrow pathology can be quite easily seen, and then there is the empty notch sign. Now coming to the secondary signs of the ACL tear. So one of the most common is the anterior translation of the tibia. So when we see the in the MRI, the posterior condyle of the femur and the posterior condyle of the tibia, they are at the same line. But when there is ACL tear, there is anterior translation of more than 5 mm of the tibia. The other signs are the uncovered meniscus sign, the second sign, the second fracture, and the buckling of the PCL. Now the normal PCL, it is a cord-like structure and it is the stronger than the ACL. And if it is torn, then there is discontinuity of the fibers. Now the bony avulsions can be best appreciated by the CT scans. Then the collateral injuries. This is the normal MCL. It lies attached to the femoral condyles, the medial and the medial femoral and the tibial condyle. But when there is a layer of fluid separating the MCL from the bone, that is the MCL injury or MCL tear. Similarly, the normal LCL is attached to the fibular head, and when there is a lax or the absence of this structure from the fibular head, there is the layer of the fluid or some whitish structure, then it is the CCL. So this is in nutshell the MRI of the knee. There are many other findings also in MRI, but for the basic MRI findings, I have limited my discussion up to this only. Thank you. Yes sir, actually we can often find in MRI's knees, if we take this slide many times we cannot find the ACL in MRIs, but in clinical examination we can find that ACL is intact. So what is the interpretation in such cases? In such cases the interpretation is either the ACL is torn or that is the wrong positioning of image. The wrong positioning is the ACL is oriented 15 degrees, means the condyle to the condyle it is like this, slanted. Okay, so the leg has to be external rotated in 15 degrees. That is a normal. If the patient has in any ways, if the MRI is done with not that rotation, if it is not maintained and the MRI is done, many times it can be found that the ACL is missing. So it is actually oriented to the 15 degrees internal actually to the condyles, the femoral condyles. So that orientation must be taken when considering the MRIs.